Good morning everyone. Today I am presenting an article, Small Round Cell Tumors of Soft Tissue and Bone. This study was done by V. et al. In the Department of Pathology and Genetics, University of Alabama, Birmingham. The article was taken from journal Archival Pathology and Laboratory Medicine, and the article is published in year 2022. Introduction. Small round cell tumors, also known as small blue round cell tumors, constitute a divergent group of neoplasms. These neoplasms are morphologically alike and characterized as a highly aggressive malignant tumors composed of relatively small round hyperchromatic monotonous undifferentiated cells with an increased nuclear to cytoplasmic ratio. The differential diagnosis of this tumor is particularly different because of their undifferentiated or primitive character. They can occur in any age group but demonstrate different age peaks for given tumor types. Although there are always exceptions, some tumors primarily affect the skeleton, such as Ewing sarcoma and small cell osteosarcoma, whereas other typically occurs in somatic soft tissues including rhabdomyosarcoma and desmoplastic round cell tumor. Moreover, the overlapping histological immunohistochemical molecular features create diagnostic challenges despite significant clinical and prognostic differences as well as therapeutic indications. Objective: to provide an overview of the current concept in the classification and diagnosis of small round cell tumor of soft tissue and bone, focusing on silent histological features, key immunophenotyping characteristics and recent molecular genetic advancement. Data sources: data were obtained from pertinent peer-reviewed English language literature and first-hand experience from the authors as practicing bone and soft tissue pathologists. Discussion: recent molecular genetic advances have identified a growing list of round cell sarcomas, thus having revolutionized the diagnosis of sarcomas and provided insight into potential therapeutic targets as well as prognostic biomarkers. The research to that end has also resulted in the reclassification of number of previously established tumor types, as illustrated in the most recent edition of WHO classification of soft tissue and bone tumors. Herein, authors have provided an overview of current concepts of small round cell tumor of soft tissue and bone, focusing on salient histological features, key immunophenotyping characteristics, and recent molecular genetic advancements. This is the table showing clinicopathological characteristic of small round cell tumors. Ewing sarcoma, it is the second most common malignant tumor of the bone in the children and young adults with a peak incidence during second decade of life. It typically arises in the diaphysis and metaphysis of the long bones. Histopathologically, it appears as a solid sheets of uniform small blue round cells with scant clear or eosinophilic cytoplasm and minimal extracellular matrix. There is diffuse membranous expression of CD99 in Ewing sarcoma along with FLI1 and ERG expression. Other entities that is round cell sarcoma with EWSR1 non-ETS fusions and CIC rearranged sarcomas shows similar clinical, histological and immunophenotypical features, but they lack pathognomic molecular hallmark of Ewing sarcoma. Coming to sarcoma with BCOR genetic aberration, this tumor is common in children and young adults with male predilection. The histological features shows primitive small round cells in a solid sheets or nesting pattern with varying myxoid or collagenous stroma. This is the image showing Ewing sarcoma. Image A is showing solid sheets of uniform small blue round cells with scant amount of cytoplasm and minimal extracellular matrix. Image B is showing atypical Ewing sarcoma showing kidney arising in the kidney showing larger atypical epithelioid cells. Image C is showing adamantinoma like Ewing sarcoma of thyroid which manifests as a lobus of small round cells. This is the image of CIC rearranged sarcoma in which we can see focal prominent myxoid stroma, variably arranged round cells, moderate pleomorphism, and image F is showing diffuse WT1 expression. This is the table showing another small round cells tumors. Small cell osteosarcoma. It is the most commonly found in metaphysis and diaphysis of long bones. Histopathologically, it shows combined features of osteosarcoma and Ewing sarcoma. The lesional cells are typically round to oval and less frequently short spindle, generally have a hyperchromatic nuclei and scanty cytoplasm. The presence of focal hemangiopericytoma like growth pattern is frequent finding. This tumor shows CD99 positivity along with SATB2. Coming to mesenchymal chondrosarcoma, it is commonly present in second and third decade of life. It is a biphasic tumor comprising of small round cells and hyaline cartilage. This tumor shows positivity for CD99 and SOX9. This is the image showing small cell osteosarcoma. In image A, there are loosely arranged small round cells, but there is no identifiable osteoid matrix. Image B is showing small cell osteosarcoma, showing it shows less like osteoid matrix with a hemangiopericytoma like growth pattern. Image C is showing mesenchymal chondrosarcoma, characterized by a biphasic appearance, having mature cartilage and hyaline cartilage and sheets of small round blue cells. This is a table showing entities of rhabdomyosarcoma, which is one of the small round cell tumor. Rhabdomyosarcomas constitute the largest category of soft tissue sarcomas in children and young adults. The subtypes with prominent small round cell morphology include embryonal, alveolar, and sclerosing rhabdomyosarcoma. Embryonal rhabdomyosarcoma is the most common subtype of rhabdomyosarcoma, typically affecting children younger than 10 years and occasionally occurring in the adolescents with predilection in white individuals. The head and neck region and genitourinary system are common sites. Histopathologically, tumor contains primitive mesenchymal cells housed with loose myxostroma admixed with variably differentiated rhabdomyoblast, which demonstrate elongation, cytoplasmic eosinophilia, and sometimes cross striation in the cells. Embryonal rhabdomyosarcomas are always positive for desmin, a key subunit of for intermediate filament in the cardiac, skeletal, and smooth muscles, as well as myogenin and myod1, both of which are transcription factors involved in myogenesis. Coming to alveolar rhabdomyosarcoma, it is more commonly present in second and third decade of life and more commonly affects deep soft tissues of extremities, followed by head and neck region. Histopathologically, it shows a monotonous population of primitive hyperchromatic round cells arranged in nests divided by fibrous septa, thus giving rise to alveolar growth pattern. This is the image showing embryonal rhabdomyosarcoma exhibiting primitive round to spindle cells as well as numerous differentiating rhabdomyoblasts. Image B is showing cartilaginous differentiation. Image C is showing the botryoid pattern of embryonal rhabdomyosarcoma, showing a variable cellular tumor with condensation beneath an epithelium lined surface. Image D is showing alveolar rhabdomyosarcoma consisting of monotonous round cells with an alveolar growth pattern. Image A is showing anti-synaptophysin immunohistochemistry, which is showing focal positivity. Image F is showing sclerosing rhabdomyosarcoma, showing a cluster of single cells in a sclerotic collagenized stroma. This is the table showing another small round cell tumors with predominant myxostroma. First one is myxoid liposarcoma. It is common in young adults, peak in 4 to 5 decades. It occurs in deep soft tissues of extremities. Histopathologically, it shows uniform round non-lipogenic cells and small lipoblast in myxoid stroma. Extraskeletal myxoid chondrosarcoma. It occurs in middle-aged group and affects deep soft tissues. Histopathologically, it shows small uniform cells in coarse strands and clusters with multilobulated growth pattern and abundant chondromyxoid stroma. Image A is showing myxoid liposarcoma composed of uniform round non-lipogenic cells and small lipoblast set in a prominent myxoid stroma with a chicken wire vascular network. Image B is showing pure high-grade myxoid liposarcoma lacking myxoid matrix An image C is showing extraskeletal myxoid chondrosarcoma characterized by hypocellular and hypovascular, blind, round, ovoid or bipolar, arranged in cords, strands and clusters. Hematological neoplasms and metastasis. It is doubtless that hematological neoplasms frequently originate in bone. Solitary plasmacytoma, bone and plasma cell myeloma along with metastasis are always top differential diagnosis for lytic lesions without identifiable matrix on imaging in middle-aged and older adults. Although the recognition of plasmacytic origin is mostly straightforward given the characteristic cytomorphological features of plasma cell, poorly differentiated plasmacytomas and those with anaplastic morphology may be problematic. Of important note, membranous CD138 reactivity for neoplastic cells in bone is not definitive marker for plasmacytic origin unless a diagnosis of hematological disease has been established. Primary lymphoma of bone is not uncommon, accounting for about 7% of malignant bone tumors. Approximately 5% of all extranodal lymphomas originate in the bone. The most common site is femur, followed by spine and pelvic bones. Lymphoma of bone may involve a single anatomical site or multiple bones. Most lymphomas of bone are diffuse large B cell lymphoma. Extranodal Burkitt lymphoma commonly involve bone. This is the image showing a poorly differentiated plasmacytoma. In this, there are sheets of plasma cells. Image B is showing therapy related myeloid sarcoma in a patient with metastatic lobular breast cancer to the bone, and image C is showing metastatic medulloblastoma. Image D is showing metastatic melanoma to the bone. Image A is showing metastatic well differentiated neuroendocrine tumor of the pancreas, and image F is showing metastatic epithelioid gastrointestinal tumor. Conclusion. Primary small round cell tumors of the soft tissue and bone constitute a diverse group of neoplasms sharing many histomorphological similarities and immunophenotypes, and they may have overlapping clinical and radiological characteristics but diverse clinical outcomes. These lesions may also demonstrate largely overlapping histomorphological features with hematological disorders and metastatic diseases, thus resulting in diagnostic challenges. Although the pathogenesis of a subset of these tumors remain to be ascertained, knowledge has enhanced our understanding of these tumors. Although numerous molecular alterations have contributed to the diversity of this lesion, recent molecular and genetic advances have led to the reclassification of some of these entities with potential novel therapeutic targets and emerging. Immunohistochemical analysis provides useful tools in characterizing these lesions and narrowing the differential diagnosis. However, interpretation of biomarkers requires a caution and judicious approach. Molecular genetic studies are often needed, especially for those with an unusual histomorphology and typical histological features, but unusual clinical presentation. Thus, correlation with the clinical radiological characteristic, recognition of silent histological features, and use of ancillary studies are critical to reach the correct diagnosis. Introduction. Coming to abstract. Introduction. Small round cell tumors of soft tissue and bone constitutes a divergent group of neoplasms. These lesions often demonstrate overlapping clinical radiological characteristics and share histomorphological and sometimes immunophenotypic similarities, but they typically have diverse prognostic outcomes, thus warranting different clinical management. Recent advances in molecular and cytological techniques have identified a number of novel molecular alterations contributing to the diversity of these lesions. Objective: to provide an overview of the current concept in the classification and diagnosis of small round cell tumors of soft tissue and bone, focusing on salient histological features, key phenotyping characteristics, and recent molecular genetic advancements. Data sources: data were obtained from pertinent peer-reviewed English language literature and first-hand experience from the authors as practicing bone and soft tissue pathologists. Conclusion: immunohistochemistry plays a vital role in rendering a specific diagnosis of narrowing the differential diagnosis in small round cell tumors of soft tissue and bones. Molecular genetic studies are often needed, especially for those lesions with unusual histological features, an uncommon immunoprofile, and unusual clinical presentation. Accurate diagnosis of these tumors necessitates recognition of silent histological features, judicious and astute use of ancillary studies, and correlation with clinical and radiological characteristics to guide clinical decision making. Thank you.